Good morning, and welcome to the first session of the Virtual Rheumatology Learning Collaborative. I'm Dr. Beth Jonas, Chief of the Division of Rheumatology, Allergy, and Immunology at the UNC School of Medicine and Chair of the ACR Committee on Training and Workforce. I will be your moderator for this first session. Later, I will be joined by Dr. Elena Gruzman, third-year fellow at the Hospital for Special Surgery in New York, who will co-moderate the questions and answers with me. The concept for this lecture series was conceived by Dr. Anisha Dua, Associate Professor of Medicine and Rheumatology Fellowship Program Director at Northwestern. What she has done is nothing short of amazing. Over the last weekend, she quickly assembled a team of 24 participating institutions to help develop and launch this unique learning opportunity for trainees. Over the next weeks, you will hear from some of the most prominent rheumatologists and specialists in their respective fields. In a moment, I will formally introduce Dr. Dua, who will kick off this 8-week curriculum. When we brought this idea to the ACR, they jumped right in with energy and resolve to make this initiative a reality. I particularly want to thank Connie Herndon, our staff member for the Committee on Training and Workforce, who has worked day and night on this for the last week. Thank you also to Ngozi Afulezi, who is our host for this series and is assisting with technical support. As of this morning, we have over 740 learners from 110 institutions in 9 countries signed up to participate. The interest in this program is truly overwhelming. We have come together to support each other and each of our rheumatology learning communities during this truly unprecedented time. It is amazing what we can do with a great idea and a ton of motivated and energetic people. I am grateful to Dr. Dua, our awesome group of colleagues, and to the ACR for their tremendous support. So before we start, just a few housekeeping announcements. All of your mics are muted. You can use the chat function at any time to make a comment, and this will be seen by all participants. If you are having any technical difficulties, use the raise your hand function, and the host will enter a private chat with you. You may type in a question in the Q&A box, and this will be seen by the speaker and the moderators. Dr. Gruzman and I will moderate the questions and answers at the end. Finally, it gives me great pleasure to introduce Dr. Anisha Dua. Dr. Dua is Associate Professor of Medicine and Rheumatology Fellowship Program Director at Northwestern. She has extensive clinical expertise in the evaluation and management of patients with vasculitis, and she serves as the Director of the Vasculitis Center at Northwestern Medicine. Dr. Dua is a former member of the Committee on Training and Workforce and is the incoming co-chair of the ACR In Training Examination Subcommittee. Dr. Dua recently assisted in the development of the ACR Guideline for the management of vasculitis by serving on the literature review team as leader of the patient panel. She is also recently selected to serve on the Vasculitis Foundation's Board of Directors. Dr. Dua is eminently qualified to present our topic today, ANCA Therapeutic Updates. Welcome, Dr. Dua.
Thank you so much, Beth. I appreciate the very nice introduction. I'm so excited for all of you to be here. And I will try to talk slow. Usually I have people slow me down while I'm talking, but since you guys can't necessarily do that, I'll try to self-moderate. And I will go ahead and get started with this first talk. Let's see here if I can. All right, here we go. So I am going to be talking to you all about ANCA induction and maintenance in severe disease. I kind of titled it Moving from Mutually Assured Destruction Towards Targeted Therapies. I'm going to start off with a little bit of background, review of ANCA vasculitis, then I'll go into induction. I always tell my patients it's kind of like trying to put out the fire. And then maintenance, which is trying to keep the fire out without causing a flood. Sorry. All right, so this is a slide I always show if I'm talking about vasculitis. Again, I'm focusing on the ANCA-associated vasculitis, and for the purposes of this talk, I'll really be talking about microscopic polyangiitis and granulomatosis with polyangiitis. So we know that ANCA vasculitis is a post-immune necrotizing inflammation. It affects the small and medium-sized blood vessels, especially in the upper and lower respiratory tracts, as well as the kidneys. So in terms of the pathogenesis, we've looked into possible genetic predispositions, bacterial or viral triggers, silica or different types of dust, environmental exposures. And we're not really sure of one specific thing that sets off this cascade of events, but I always, again, tell my patients it's usually sort of the perfect storm of everything coming together. They're walking this fine line and something tips them over into this autoimmune condition. So on the panel, you can see that there's activated neutrophils. The neutrophils, the PR3 and MPO molecules or proteins come to the surface of the neutrophils where the ANCA antibodies can attach. And this can lead to priming of the neutrophils or increased activation, more stickiness of the blood vessels essentially. And so these neutrophils stick in to the blood vessels and sort of migrate through, releasing oxidative radicals and inflammatory cytokines, causing damage to the blood vessel wall and then downstream damage to the organ which that blood vessel feeds. And it sort of develops this sort of feedback loop and you get more neutrophil activation and more damage. So we know that in terms of ANCAs, GPA is more commonly associated with C-ANCA or PR3 antibody positivity, and MPA is more often associated with P-ANCA or MPO positivity. If you do see an atypical or discordant pattern or pan positivity, you want to think about drug-induced vasculitis. Cocaine can be cut with levamisole, which can cause sort of a pan positivity and a very similar presentation to our other ANCA vasculitides. Classification of ANCA vasculitis, according to the ANCA specificity, is more strongly associated with outcomes than classification by clinical subgroupings. And this is supported by genetic studies that link MHC subgroups and SNPs with PR3 positive vasculitis as distinct from MPO vasculitis. So systemic involvement, we know that ANCA vasculitis can really affect so many different organs. You can see sort of a wide array here with ocular involvement. You can get proptosis, pseudotumors, scleritis, inflammation of the cartilage causing nasal bridge collapse or that saddle nose deformity, tracheal stenosis, subglottic stenosis. You can get cavitary lesions in the palate of your mouth. Also cavitary lesions or destructive sinus lesions as well. Gingival hyperplasia here, you get this strawberry gum type of finding. And a lot of different types of skin findings can be associated with ANCA vasculitis. You can see purpura here on the bottom panel, your classic crescentic glomerulonephritis, post-immune. And then you can get cavitary lung involvement and also nerve involvement with mononeuritis, destruction of the nerves, and then weakness, muscle wasting. So these are just some of the features that you can see with systemic ANCA vasculitis. So I'm going to focus again on therapies, and first I'll talk about induction, so putting out the fire. How do we do this? I always like to put everything in terms of a case because that's what I do. So we have a 45-year-old Caucasian male who presents to the ER with 6 months of fatigue and notes worsening shortness of breath over the past 3 months. He presents now because he started coughing up blood since yesterday. In the ER, his evaluation shows tachycardia. His blood pressure is normal. He's slightly pale. His labs show a creatinine of 2.3. His urine has 2 grams of protein and has red blood cell cast. You get a CT scan, and the CT chest shows ground glass opacities. In terms of, then he gets admitted to the hospital. Eventually in his hospital findings, he has a renal biopsy that shows crescentic post-immune glomerulonephritis. His bronch shows diffuse alveolar hemorrhage, and he is found to be MPO positive. So in addition to pulse steroids, what medications should be started? And I know you guys can't answer this, but this is really just to think about what you would use or what you would consider using. And then we're going to talk a little bit about the evidence behind why we might make some of these choices. So cyclophosphamide, 15 mg per kg IV, rituximab, 375 milligrams per meter squared times body surface area, weekly for 4 weeks, oral cyclophosphamide, or plasmapheresis in any of these above regimens. Okay, so the use of Cytoxan and prednisone has really transformed ANCA vasculitis from a uniformly fatal disease to a chronic relapsing disease with the mortality of about 25% at 5 years. So we know that Cytoxan can very often put these patients into remission, 93%, but 50% of them suffer side effects. And some of the side effects you can see listed on the right, including cystitis, infertility, bladder cancer, lymphoma, and very importantly, infection. And the discovery of new induction agents has driven improvements in morbidity and mortality from the disease, but at least 50% of those who respond to initial therapy experience a relapse within 5 years. So even if we get these patients into remission, half of them are having pretty intolerable side effects and half of them are relapsing. And I just want to point out Fauci here in the corner because he's a boss. So what are our goals? Our goals here are to prevent or to control inflammation, prevent end organ damage, and of course, induce remission. And then after that, we would really like to minimize Cytoxan exposure and then prevent relapses. So let's talk a little bit about where we've been. This is not inclusive of all the trials that have gone on, but I just want this to sort of point out, really, we have come a long way. So if you see before the 2000s, we've had steroids and then Cytoxan and steroids. And then since the 2000s, and especially since like 2010, in the last 10 years, we've had an amazing number of trials and collaborative trials across countries and across institutions to try to figure out what we can use in helping these patients with ANCA vasculitis. And again, I'm going to go into a couple of these in more detail as we go through the talk. But we really have come a long way, and it's a very exciting time to be in vasculitis. So in terms of review of induction regimens, these are some of the major trials that have influenced our decisions in terms of what therapies we use when we're trying to figure out how to induce remission in our patients. Whenever I'm looking at trials, it's really important to look at the patient population. So we know which drugs are being compared usually, but it's really important to see how applicable these regimens are to different types of patients, because that really guides your clinical decision-making. So the Cyclops trial was one of the earlier trials that looked at oral versus IV Cytoxan to see if we could get that same benefit using IV Cytoxan. And there was no difference in survival or time to remission, so you can use oral or IV Cytoxan. There was less leukopenia and a trend towards more relapses with the IV dosing, but again, it depends on your preference, but this trial sort of showed that oral or IV Cytoxan are both effective in inducing remission. But we know about all those side effects, and so let's talk more about what else we can use. The NORAM trial was looking at methotrexate versus oral Cytoxan, again, paying attention to the inclusion group. This was GPA or MPA, new patients, and the creatinine was less than 1.7. So we don't really want to use this, of course, in patients with renal involvement. This is really more what we call limited vasculitis, but really it's talking about upper, like sinonasal type involvement. And methotrexate was not inferior to Cytoxan. The time to relapse was shorter with methotrexate. So it can be used. I have some patients who I induce and maintain with methotrexate, but it's usually milder disease. The MEPEX trial was looking at ANCA positive glomerulonephritis, and these were sick patients with creatinines greater than 5.8. And this was looking at plasmapheresis versus pulse steroids alone without plasmapheresis. Both groups had oral Cytoxan and prednisone at their baseline. And there was decreased progression to end-stage renal disease in the group that had pheresis, but no mortality benefit at 1 year. And of course, I'm going to go in a little bit farther to the PEXIVAS trial later. MyPsych, again, this was looking at mycophenolate. This was not shown to be effective compared to IV Cytoxan, so we don't really use it as much, though there was a prospective trial in very mild renal involvement in MPO positive patients where it can be used, but again, it's sort of third, fourth, fifth line. And then of course the rituximab and RAVE trials. These really led to our, the FDA approval for rituximab and induction for ANCA vasculitis. The rituximab trial had new ANCA patients with significant renal involvement, so they were sick patients. But again, it's important to look at what was used in the trial, and it was rituximab weekly for 4 weeks. But that rituximab group also did get 2 doses of IV Cytoxan, and this was compared to IV Cytoxan alone. There was a lot of side effects in both groups. It was equal. Death, end-stage renal disease, and relapse rate were similar at 24 months. And then the RAVE trial, of course. So new or relapsing GPA or MPA, they did have renal involvement, but there was no creatinine greater than 4 and nobody on mechanical ventilation. So in this trial, it showed that rituximab was not inferior to Cytoxan in this population, and it seemed to be better in patients with relapsing disease or PR3 positivity. Also, it's important, like I said, to look at what the trial design is. In this trial, rituximab was given weekly for 4 weeks, and then there was no maintenance beyond that. The Cytoxan group was induced with Cytoxan and given azathioprine for maintenance. So this does sort of make you understand a little bit why some of the relapses that happened in the rituximab group happened a little bit later on in the trial, because they weren't really given that next maintenance dose. Okay, so this This information helped us come up with the Vasculitis Foundation and the ACR. These were presented at the last ACR meeting, but we were trying to come up with guidelines for management in severe GPA and MPA. And our recommendation is that in patients with active severe GPA or MPA, we conditionally recommend using rituximab over cyclophosphamide for remission induction. Both pulse IV and high-dose oral glucocorticoids can be used as initial therapy for patients with active severe GPA and MPA. Okay, so to pherese or not to pherese, that is the question. And this question was asked and really under a huge collaborative effort from many countries and many sites. It tried to be answered in this recent publication in the New England Journal of Medicine. And I'm going to talk a little bit about the structure of that trial and some of the outcomes. So again, this was severe ANCA vasculitis patients with renal involvement or lung alveolar hemorrhage. 706 patients were in the trial with severe disease, and they were followed for 1 to 7 years. This was 95 centers, 16 countries, so a really huge undertaking. They were given standard therapy with cyclophosphamide or rituximab. And again, this was dealer's choice. So whoever was enrolling the patient would decide how to induce them. But then they were randomized. And they were randomized either to no plasma exchange or plasma exchange. And then beyond that step, they were randomized again to either the standard dose glucocorticoids, which we've been using for treatment of ANCA vasculitis, or a reduced dose regimen where they were weaned down to 5 milligrams of prednisone a day by week 15. Again, this is just another way of looking at the glucocorticoid dosing regimen. All the participants did receive pulse glucocorticoids up front, or were allowed to. And then you can see that first week is about the same in terms of prednisone dosing, but in the reduced dose group, they tapered down significantly quickly compared to the standard dosing regimen. So in terms of the primary outcome, which was end-stage renal disease or mortality, you can see here when you split the groups up based on whether they received or did not receive plasma exchange, the numbers were pretty similar. So 28% versus 31% at a year. And there were no differences based on age, creatinine at entry, ANCA type, rituximab or Cytoxan used for induction, or the presence of alveolar hemorrhage. And the other question that this trial tried to answer is there any chance we could use less steroids? I mean, we all know the millions of side effects from steroids, and is there any way we can get away with using less, but actually still control the disease in our patients? And this is huge. So the outcomes here, obviously in the reduced dose group, there was less steroids used. That's not surprising, but it was 54% less at 3 months. And I think it was about 60-some% at 6 months. So obviously less steroids in the reduced dose group. The death or end-stage renal disease, which was that primary outcome, was equal in both groups. So 28% versus 36%, regardless of your dosing regimen of steroids. And serious infections were seen more often in the standard dose group. So you had less infections in patients who received less prednisone. Again, not surprising, but important for us to know that we could get basically equal efficacy with less risk of infections by using less steroids. And this is just a graphical representation of that data on the bottom here. This is just another, I thought it was a nice sort of graph cartoon showing what this trial was trying to answer. So the interventions, again, were plasma exchange and oral glucocorticoids. And even when you split them up by whether they had alveolar hemorrhage or severe kidney disease, you could see that even in those subgroups, you had benefit or equal benefit with or without plasma exchange. So there was no difference in terms of the outcomes there. And reduced dose glucocorticoids were better essentially and had less infection. Again, like I mentioned before, it really is important to look at the population that you're treating. So just things to note and some critiques that have come out about this trial and whether, the question always comes up. So is there no role at all for plasmapheresis in these sick patients? Is there any patient you would ever use this, pheresis with? So in terms of the patients undergoing dialysis, there was about 20% across the board that were on dialysis in this trial. But one thing to note is pulmonary hemorrhage. Less than 10% had severe pulmonary hemorrhage across the board. So there was a little bit less pulmonary hemorrhage in terms of severity. And then in terms of what medication was used for induction, again, I said it's dealer's choice, and this was a multi-country study. So rituximab wasn't used as often when you look across the board. It was about 15% induction with rituximab. So of course, there is the question, if somebody is induced with rituximab and has severe pulmonary hemorrhage, is there any role, is that a patient who you might use pheresis in? And I think that's a reasonable question. I think this trial was very well designed. I mean, another piece to it is, if they didn't discuss really the biopsies. So if someone has very active crescents on biopsies, on their kidney biopsy, does that mean that maybe we should try to clear those antibodies by using pheresis? So we don't have that data. Again, I think this has really informed me in terms of not pulling the trigger on plasma exchange. And I think there would be very, very few cases where I would, but that's, again, those are the questions that have come up with this trial. Based on that data, our recommendation from the ACR and Vasculitis Foundation, or our preliminary recommendations, are that in patients with GPA or MPA with active glomerulonephritis or alveolar hemorrhage, we conditionally recommend against adding plasma exchange to cytoxan or rituximab. And in patients with active or severe GPA and MPA, we conditionally recommend using a reduced dose glucocorticoid regimen over a standard dose glucocorticoid regimen for remission induction. So again, moving away from plasma exchange and definitely using less steroids than before. So this is a very important study for us to be aware of and eventually translate into our practice. So is there anything new on the horizon? What else is coming down the pike, or what else is maybe out there? Complement. I know when I was in med school, and actually probably still now, when someone starts talking about complement, my eyes glaze over and I get a little bit like, oh God. But it's really important because it's a new target in ANCA vasculitis, and it really, as we've understood the role of complement in ANCA vasculitis, it's helped us develop this new target. So complement, without going into a ton of detail, is part of our innate immune system. It consists of a number of small proteins found in the blood. It assists in clearing microbes and damaged cells from our body, and it stimulates activation of our immune system. So a new drug has been developed that targets the C5a receptor that is found on activated neutrophils. So this drug, now named avacopan, is an oral C5a receptor blocker. We know that C5a can lead to inflammation and increased permeability of the blood vessels, and it can also play a role in this priming of the neutrophils that I talked about a little bit earlier. So it is a good target for trying to shut down some of this priming and inflammation and the downstream damage that happens with vasculitis. The nice thing about this medication is that it is oral, and it specifically targets the C5a receptor. That's a little bit different than, not a little bit, it's different than eculizumab, which blocks C5, which then again will downstream have effects on the MAC complex, or C5b through 9, whereas this drug more specifically targets that receptor of C5a. So by blocking that receptor, avacopan is thought to reduce vasculitis by reducing neutrophil activation, accumulation, and adhesion, as well as vascular permeability. So what are the trials that have been done around this mechanism? The CLEAR and CLASSIC trials were two of the phase 2 trials. The CLEAR trial was to see if avacopan treatment would allow for elimination or reduction of high-dose steroids without compromising efficacy or safety, and the CLASSIC trial was looking for additional safety concerns or signals. So for the CLEAR trial, there were 67 patients who were given standard of care, which was again rituximab or cytoxan, and the outcome here was BVAS at week 12. And they gave one group 60 milligrams of prednisone, one group prednisone 20 milligrams, and avacopan 30 milligrams twice a day, and the last group avacopan 30 milligrams twice a day only without prednisone. And all of the treatment groups were comparable in clinical improvement across the board. So the patients who got the study drug had a more rapid onset of improvement. Avacopan appeared safe and well tolerated in the trial. Again, as I mentioned, there was no impact on that MAC complex or upstream activities in the complement system based on the specificity of this receptor and how it works. And so the question obviously rose, can avacopan replace chronic steroids in the treatment of ANCA vasculitis with at least equal efficacy? And this led to the phase 3 trial. And here's the design of that phase 3 trial, and the results have not been published yet, and this is not FDA approved. But the trial included 331 MPO and PR3 positive patients with new or relapsing disease. And as you can see here, the test group got avacopan 30 milligrams twice a day. They were induced with cytoxan or rituximab, similar regimen to the RAVE trial. But as you can see here, there was no prednisone in the trial design in that test group. And the control group got the regular induction with prednisone 60 milligrams a day, tapered down to 0 over 20 weeks. So the idea for this trial was asking the questions, can avacopan effectively induce remission in combination with Cytoxan or rituximab without the use of steroids? Can remission be sustained at 1 year without the use of steroids? And remission for this trial was defined as a BVAS of 0 and no steroids for the prior 4 weeks. And here are some of the preliminary results. So you can see remission at 26 weeks and remission at 52 weeks. And the group, the study group had a significant, actually was superior at 52 weeks and non-inferior at 26 weeks. If you look at the GTI, or the glucocorticoid toxicity index, not surprisingly, the patients who did not who were not in the steroid group had a lot less steroids and did better and didn't have as much toxicity from steroids. And you can also see here a small signal looking at the GFR. So the patients in the avacopan group seemed to have a better improvement in their baseline GFR from admission or from an enrollment to the end of the first year. Serious adverse events were equal across both groups, and avacopan significantly had a better, was significantly better than the standard of care when you look at patient-reported outcomes, such as the SF-36 at week 50 or at week 26 and 52, and the EuroQol 5D. So again, this is preliminary information, but it's very exciting. So in terms of induction, just some take-home points on induction before I move into some maintenance therapies. Cytoxan and steroids have decreased mortality in ANCA vasculitis, but we know that both of these have very significant toxicities. Oral and IV Cytoxan are comparable in efficacy, though lower cumulative dose in IV with a trend towards more relapses. Rituximab is effective in induction for ANCA vasculitis. It's not inferior to Cytoxan, and it was superior in relapsing disease. But again, it's important to remember that RAVE also had no patients with a creatinine higher than 4 or mechanical ventilation, and rituximab also did use 2 doses of IV Cytoxan. Plasmapheresis does not improve mortality or progression to end-stage renal disease in severe ANCA vasculitis. A low-dose steroid regimen had equal efficacy and less infections than the standard regimen. And we're awaiting, FDA approval for avacopan, but it could be game-changing for ANCA vasculitis. So we know that people we can induce them, right? We have the tools to induce them. And again, there are some people who this induction doesn't necessarily even work, and we've got to try a lot of things to get them under control, but we've tried to put out the fire. The problem, as I mentioned before, is that the disease returns. In the RAVE trial, many of them achieved remission, but at 18 months, the rate of relapses was 32% and 29%. Again, in rituximab, the sustained remission was 50%, so half of the people are still having relapses. And we know from before that patients that are prone to flare include those with the diagnosis of GPA, PR3 positivity, and those who have had a previous flare. So how do we try to keep these patients in remission? This takes us to maintenance. So keeping out the fire without causing a flood. So how much is too much? How do we keep them there and not just knock their immune system out forever? So I'm going to focus this next part on the maintenance, obviously, section here. So again, back to our case. We have a 45-year-old male. He was treated for MPO positive ANCA vasculitis with pulse steroids and IV rituximab. He was successfully extubated and had renal recovery. His new baseline creatinine is 1.8 with mild persistent 1+ proteinuria. His ANCA titers are now undetectable. He follows up in clinic and wants to know what the next steps are. So A, dose rituximab 1 gram every 6 months. B, start azathioprine 2 mg per kg. Follow his ANCA titers and redose rituximab when his ANCA levels rise or if he develops new clinical symptoms. D, start rituximab 500 milligrams every 6 months. Or E, any of the above, and just try to get them down off of prednisone with a goal of 0 by month 6. Again, I luckily am not giving you straight answers to these questions. I just want you to think about what goes through our mind when we're seeing these patients and trying to make those clinical decisions, and then try to touch on some of the data that helps feed those decisions. And again, it's not always the same answer for every single patient. Okay, so just to review again, some of the older trials in terms of maintenance. So this, part of the toxicities from Cytoxan that we worry about are because historically that was really all we had to not only induce, but also maintain patients in remission for ANCA vasculitis. And so, we couldn't get them off this drug and they would develop the leukemia, the infections, and bladder toxicity, everything I mentioned before. So the Cycazarem trial was looking at Cytoxan versus azathioprine. Can we replace the Cytoxan and use something a little less toxic for long-term maintenance? of remission. And so it looked at 155 new ANCA vasculitis patients in remission on oral Cytoxan and randomized them to either azathioprine or Cytoxan. And what they found was that there was no difference in relapse rates or adverse events at 18 months. So patients were able to do just as well if we used azathioprine for maintenance. And so that sort of replaced Cytoxan as a maintenance agent. And then, you know, we're rheumatologists, we love methotrexate. So we should see if methotrexate can do just as good a job as azathioprine. So the WEGANT trial was a prospective open label trial. And this looked at methotrexate versus azathioprine for maintenance after induction with IV Cytoxan. In this trial, maintenance was discontinued after 12 months, and that's earlier than we tend to do for our vasculitis patients. We're saying at least 18 months, if not longer. I tend to use longer maintenance in patients, especially with higher risk factors for relapse. And basically what this trial showed was that azathioprine and methotrexate were both effective in maintaining patients in remission, or equally effective. Again, you obviously want to avoid methotrexate in patients with a low GFR or women of childbearing age. But you can see the relapse-free survival, even when it was carried out, was similar across both groups. And again, this data just shows you that those PR3 patients are the ones that are more prone to relapsing. So methotrexate is not safer than azathioprine with regards to side effects, infections, or malignancy, but it can be used as a maintenance agent as just as well, essentially, as azathioprine. So they're equal. All right, so what about mycophenolate? That's another one. You know, we have certain drugs at our disposal. We want to see where all we can use them. So we looked at mycophenolate against azathioprine to see if we could use that for maintenance. This was the IMPROVE trial. And essentially, this was open label, and 154 new ANCA vasculitis patients were included. And as you can see from the graph on the right side of the screen, that mycophenolate did not do as well as azathioprine. I have a few patients on this for maintenance, and they're becoming less and less frequent because you know, you can basically consider it if azathioprine or methotrexate is contraindicated, and for some reason you can't use rituximab, which I'll get into. But it was not shown to be as effective. So azathioprine beat mycophenolate. There are no head-to-head trials between mycophenolate and methotrexate, but we can assume based on, you know, the transitive property, I guess, that azathioprine and methotrexate are similar, and mycophenolate seem to be less effective. Okay, so moving on to one of our other favorites, rituximab, of course. So azathioprine versus rituximab. The MAINRITSAN trial was designed to ask the question, or answer the question, you know, we now know that we can use rituximab for induction. Can we use it for maintenance? And this looked at 115 patients randomized to either get rituximab 500 milligrams on day 0, 14, and then every 6 months up till month 18, or azathioprine starting at 2 mg per kg and then sort of tapered down to a 1 mg per kg dosing. The primary endpoint of this trial was the rate of relapse at 28 months. And you can see from the numbers here that more patients who were in the azathioprine arm suffered from relapses. The adverse events were similar in both arms, but more patients with ANCA vasculitis had sustained remission at month 28 with rituximab than with azathioprine. There was no difference in plasma immunoglobulin levels between the groups, and the rate of infections was comparable. The relapse rate was lower across the board than expected in both groups, and possibly this was because of the long-term use of low-dose prednisone, which was continued for at least 18 months. And most patients in this study, again, remember to look at who is in the trials that we're talking about. Most of the patients in this study were PR3 positive GPA patients, so it may be less applicable to MPA or renal-limited vasculitis. But from this trial, I think you can say that rituximab 500 milligram dose every 6 months is superior to azathioprine in maintaining remission, especially in that PR3 positive ANCA vasculitis patient. So rituximab beat azathioprine based on this trial, but again, it is also important to think about cost. I'm not sure if these numbers are updated, but rituximab is a lot more expensive than azathioprine, though now it is approved. So most insurances, at least here in the US, will cover it. The 5-year follow-up data from this trial showed that maintenance therapy with rituximab remained significantly superior to azathioprine. The major relapse-free was 72% versus 50%, and rituximab arm had less minor relapses as well. So from this trial and others, other observational trials, our guideline recommendations for maintenance are that in patients with severe GPA or MPA who have entered remission with cyclophosphamide or rituximab therapy, we conditionally recommend using rituximab over methotrexate or azathioprine for remission maintenance. Again, the ideal dose is not specified or clear. MAINRITSAN used 500 milligrams IV. The ritazaram trial, which I mentioned earlier, used 1 gram IV every 6 months. In some cases, we have to dose every 4 months. In some cases, we can try to space it. But that does lead to the question, how often should we redose the rituximab? And is there anything that can be used to guide redosing? Which led to the following trial, MAINRITSAN 2, which is rituximab versus rituximab. So in this trial, basically, we were saying, once we have somebody in remission and we want to figure out how to dose them, they split it up into 2 arms. So the first arm was rituximab up front, and then they basically monitored patients' ANCA status and the CD19 positive B cells. These were monitored every 3 months, and basically you would dose those patients. This is the tailored arm. You would dose those patients with 500 milligrams of rituximab if their B cells repopulated, so if the CD19 count became positive, if they had been ANCA negative and they became positive again, or if their ANCA titers rised significantly. The other arm was this fixed dosing arm where they received rituximab 500 at day 0, 15, and then again just standard given every 6 months for the 18 months. The outcomes on this trial in the tailored dosing versus fixed dosing, you can see that the relapse rate in tailored dosing was 17% versus 10% in the fixed dosing. The number of infusions, not surprisingly, was lower in the tailored dosing arm as opposed to the fixed dosing arm. And the number of adverse events were lower in the tailored dosing arm. The caveats here are that there were more relapses overall in the GPA group. So, is there a group of people who maybe you could think about doing this tailored approach with, where they have lower risk factors for relapse? It's possible. And flares can occur even when patients are B-cell depleted or their ANCAs are negative. So you can't always use those to guide whether or not to dose. But from the MAINRITSAN True trial, we came up with the recommendations that patients with severe GPA or MPA on rituximab for remission maintenance, we conditionally recommend scheduled redosing of rituximab over using the ANCA titers or the CD19 B cell counts to guide redosing of rituximab. So for now, essentially, I'm redosing most of my patients every 6 months, or sooner if they do show signs of clinical flare. And then the recommendation is that we conditionally recommend against dosing immunosuppression based on ANCA titers alone. So in terms of the take-home points on maintenance, methotrexate and azathioprine are both effective maintenance agents in ANCA vasculitis. Rituximab 500 milligram dose every 6 months is superior to azathioprine in maintaining remission, especially in that PR3 positive ANCA vasculitis patient group. And currently we recommend redosing rituximab on a fixed schedule rather than monitoring ANCA and B cell repopulation. So overall, the take-home points on induction and maintenance therapies for ANCA vasculitis, a lot of exciting research is being done. There's a lot more at our disposal for both induction and maintenance of remission. So we have a lot better targeted therapies to try to treat our patients and keep them under control, or keep their disease under control, not them. As we find one answer, many more questions arise. PEXIVAS has shown us that we can use less steroids than we previously thought and to not pherese. With an increased understanding of the role of complement, we're moving towards a possible steroid-sparing agent in ANCA vasculitis. And trials are being conducted to look at how and when it's safe to stop these drugs in our patients. And I didn't think I had time to go into these as much, but patients often ask us, how long do I have to be on this? When can I stop? And the MAINRITSAN 3 trial is looking at, can we sort of stop after a certain amount of time? Can we stop patients from getting their maintenance dose of rituximab? Is that safe? And the TAPER and MAINIPSIM trials are looking at prednisone dosing in the same fashion to see is there a benefit to keeping patients on some sort of long-term low-dose prednisone, or can we actually stop prednisone in these patients? And which is the population that's at higher risk of relapses? And so do we need to continue treatments longer in those patients? So these are all questions that we're trying to answer, and hopefully will with time. I want to acknowledge from the vasculitis guidelines committee, this was a huge effort and from many, many people trying to go through the literature that's been there to try to inform our recommendations. And then, of course, for this, this collaborative that I'm super excited about, Sarah Fentis is my fellow who brought up the idea to me, and then I sent a couple emails, and this entire awesome group on the right all signed up and got excited about it. Connie has put she's been tireless. She's helped so much in this last week, just putting all this together and making this accessible for so many people. Ngozi, who's doing all this tech and going to be on all of the talks moving forward, Beth Jonas, for all of her help this last week, and hopefully for picking out the easy questions to ask me after I finish up here. And then Phil Seo for really populating, like sending out multiple emails to get amazing lectures on the schedule. And just the many program directors and faculty lecturers who made this possible. I'm really, really excited about it. And I hope that you guys all continue to participate and have some sort of learning during this really hectic time. This is just the schedule going forward. So the next talk will be on Wednesday morning by Dr. Gensler on cases and mimics in axial spondyloarthritis. And again, this lecture and all of them will be recorded and posted through the ACR the day after the lecture is given. And with that, I will stop and take any questions that have come in. Thank you, guys.
Thank you, Anisha. That was really wonderful. There's a tremendous amount of literature that you reviewed for us, and we greatly appreciate that. I'm going to invite Dr. Elena Gruzman to the mic now. Dr. Gruzman is a third-year fellow at the Hospital for Special Surgery, and she is going to be my co-moderator. And Dr. Gruzman, you have the first question.
Absolutely. Dr. Dua, thank you so much for this great lecture. And thank you everybody for sending questions in. So we have a lot of them. One of the first questions is, in what type of patient might you still offer PLEX despite the PEXIVAS data?
So yeah, I think that I touched on, I kind of felt like that would be a question. I tried to nip it, but I think honestly, there's going to be a slower, everyone's much more excited about the steroids, right? So everyone's really excited that the PEXIVAS trial showed you can use less steroids. And I think people are going to adopt that sooner because it's something that we wanted to hear, definitely. We want to know that we might be able to control our patients using less steroids. I think clinically it's hard for us when we see a really sick, crumping patient to not pull the trigger and sort of like throw the kitchen sink at them and just give them everything we can think of. And, you know, pheresis is on that list of things we can try to give them. I think that, again, I mentioned the people who are a little bit underrepresented in the trial would be those severe pulmonary hemorrhage patients. Of course, if someone has GBM antibody or another condition, then pheresis I would use. But those severe pulmonary hemorrhage patients, maybe who got induced with rituximab, and maybe if I saw, again, I don't have the data on this, if there was very active lesions on that biopsy, and I felt like I just needed to try to clear those antibodies, that might be a patient where I would consider pheresis. But I really think personally, I'm going to really not pull that trigger. I don't know, unless I'm just really freaking out. But I really think that this data is good. It's over 700 patients. I mean, that's an amazingly large trial in this very rare disease. And so I think we have to take that information at face value. And so I don't think I would think across the board, I would really try not to use it.
Got it, absolutely. And then a next question, in what cases for induction would you use cyclophosphamide over rituximab or combine both? Do you have some examples?
Yeah, I think that's a very interesting question. Honestly, for a while, I use more rituximab for induction, and again, that is with our guidelines. But I, for a while, was very concerned in those patients who were mechanically ventilated and having rapidly progressive renal failure on dialysis, because those weren't included in the RAVE trials. And then again, in that rituximab trial, they did get those 2 doses of IV Cytoxan, so I didn't really know which way to cut it in terms of, was that really what helped them, or was it the rituximab? So generally, I go to rituximab first, but when I'm trying to think about the patient population where I would consider IV Cytoxan, it would probably be in those patients who are mechanically ventilated and rapidly progressive renal failure on dialysis, partly because I think it will kick in first. So I've definitely had patients in that group where I'll use that first dose of IV Cytoxan in the hospital, followed by rituximab. And I'll actually sort of do a combination where I dose 1 or 2 doses of Cytoxan and then also rituximab, and then maintain them with rituximab, basically to just try to put it out, but minimize that amount of Cytoxan that I'm using. Yeah.
Understand. Okay. Thank you. All right. Do you have any experience with the urolupus regimen in vasculitis? Like a lower dose?
I do not. I mean, I know the data in lupus. I think that with rituximab's efficacy in ANCA vasculitis, there might not be as many other trials looking specifically at steroids, or sorry, at cytoxins limiting regimens. I understand the utility of it. I think if the rituximab data wasn't so impressive, then we would be looking at those types of regimens to see, you know, the same way we looked at steroids, can we get away with less? I think that question can apply to cytoxin. Again, we borrow our dosing for a lot of these drugs, especially initially from the onc literature or from other specialties, because we don't know exactly what dose you need. So, but yeah, that's a long-winded way of saying, I think that because of how effective rituximab is in inducing remission, I don't know that we'll have many answers to that specific question, but I do think there is a role for sort of like a low dose cytoxin combination with rituximab in some of these really sick patients. And I think that that has been looked at by some of the nephrologists. And I think there's probably more to look at there in terms of combination therapies and patient populations, subgroup populations that would actually benefit from that combination dosing.
Absolutely.
Anisha, I think you mentioned this a little bit, but I think it's worth talking about again. And the question is regarding the use of ANCA titers to monitor disease activity. How do you use that in your practice? And what advice can you give us on that?
So I used to, my practice with that has changed. I used to not check it at all. And I figured, well, I check it not at all. That's a lie. I check it up front. And then I would check to see if after induction, if it became negative, because we know that if it stays positive, especially with that PR3 positivity, if you stay positive, you're at higher risk of relapse. So I would look for it. I would look at it from that perspective. But after that, I wouldn't be continuously checking it. And then more recently, as the MAINRITSAN studies came out and we were using rituximab for maintenance, I was like, maybe there is some role for this. And so I started checking it a little bit more often on my patients, along with that B19 count for repopulation. But again, we see people flaring just even with no ANCA titers and no repopulation. So you can't use it alone. I do think that there's a subset of my patients where I'm checking it more often, and that's really my patients who I think are at lower risk of flare. So that MPO positive patient who's been doing well for a while, if I can just continuously, if I'm every 3 months or so checking their ANCA titers and seeing that they're consistently negative, I have been and then eventually it goes positive. I have been trying to space out a couple of those patients in terms of their Ritux dosings to see if maybe I can get away with less. And that really stable patient who really hasn't flared in the last 4 or 5 years, I'm spacing it out and checking those titers in that population. And I'm actually checking it more often even outside of that population, just to see, because again, every patient's different and there are people who they really do follow those titers. And so, you know, I'm checking them, and if there's somebody I see, they start coming in with their clinical symptoms of a flare, and I see that their counts have just gone up, their B counts have increased, or their ANCA titer has flipped, I'm using those to help inform my decision. Again, it's never based on one lab value. It's always the combination of their clinical symptoms and everything else. But I will use that as part of my decision-making algorithm in whether to redose or not.
Some of our attendees are asking whether you prefer 500 or a gram of rituximab every 6 months or every 4 months, depending on what's going on with the patient. What's your strategy with the maintenance? With
yeah, no, so my go-to is 500 every 6 months. That's my standard. If I have somebody who is, who I know it sounds funny, I mean, all these vasculitis patients are sick, but if I feel like somebody is really sick and I'm not, you know, and I've just barely gotten them off of the prednisone at the time for their redosing, I may use a 1 gram dose for that first maintenance dose and then switch over to 500. My standard though is the 500 milligram dosing every 6 months. And then if they show clinical signs of a flare, or if I'm pulling down prednisone and they're flaring, then I might do that dose early at the 4-month mark. Again, also, if I'm using the 500 milligram dose and they're doing pretty well, but then I see that they're starting to get worse, I don't consider that a failure of the rituximab maintenance. I would then increase the dose to 1 gram and use that dose to see if maybe that's the dose that they need to stay in remission, and use that at the every 6-month mark. Sorry, I was kind of talking over. Did that make sense? So basically 500 milligrams every 6 months is my standard. If they seem like they need more based on clinical symptoms, then I'd go to a gram. And if they seem like they're flaring too soon before that dose, then I would increase it to the Q4 month dosing. That's
And
essential.
Anisha, what about the induction dosing of rituximab? Do you have a preference to the 4 doses versus the 2 doses? This comes up all the time.
Yeah, I tend to use, again, if they're super sick, I'll say once a week. If they're going to be in the hospital for more than a week, then I'll try to do that second dose in the hospital and do it weekly. But for the most part, I'm doing a 1 dose and then another dose 2 weeks later. Part of that is because people are coming from so far away, and organizing their infusions and making sure they come back for that second dose, compliance, that kind of stuff can be difficult. So I tend to lean towards a gram followed by another gram 2 weeks later. There's a few patients where I'll use the weekly dosing, but I don't think we have a very clear which is the right answer to that. And I think it's going to vary from center to center. And insurance approval wise, I haven't had trouble getting either. So.
Yeah. The other things that are coming up on the questions, a number of people are curious about neurologic manifestations of ANCA vasculitis. Would you consider that a serious manifestation? What's your approach clinically to treatment of neurologic disease? I guess mostly it would be mononeuritis.
Yeah, I think mononeuritis is difficult, and I do think of that as severe disease. I know we always say severe disease, kidney disease. But that's not true. And some of the most difficult things to treat are some of these and live with are these neurologic complications of mononeuritis. And also one of the other most difficult things to really get control of is that tracheal stenosis and subglottic stenosis. Those are features that really change somebody's quality of life. And the damage is very difficult, if at all possible, to reverse. So I tend to treat those manifestations really aggressively up front to try to avoid the damage that can happen down the road, because again, it's quite debilitating. And so I use, those are again, places where I would consider higher doses for rituximab for maintenance, or I would also consider Cytoxan in those patients. But also looking at some of the other antibodies and what else is going on with them, their age, the regular stuff you take into consideration when you're choosing a drug for a patient. But I do consider that a severe manifestation and would treat it aggressively. So
and do you have a preference for induction? Like say someone presented with mononeuritis as their major manifestation and you had the choice of rituximab or cyclophosphamide. Are there any data that supports a decision of one over another, or how would you approach that?
I don't think I don't feel like there's specific, I'd have to look, but I don't think there's specific data between those two, just looking at neurologic manifestations. I think we tend to pull from the neurology literature, and they have used, both. And so we try to extrapolate some of their trials. Like I said, I'm here and I lean towards rituximab. So I still would try rituximab. And if it doesn't work, then I'd switch to Cytoxan, and vice versa. If I tried Cytoxan, then I'd switch to Ritux if it doesn't work. Again, part of it is how rapid the onset is. Rituximab takes a little bit longer to kick in. So if something's rapidly progressing, kind of like where you see it like it's happening before my eyes, then sometimes I pull the trigger in those cases to use Cytoxan up front. I don't know. Again, there might be data out there. I don't know.
And how about Bactrim use? So a lot of people are asking, now that the steroids are going down faster, do you still keep it on if the patients are on, either cyclophosphamide or rituximab or?
Yeah, no, that's a good question. I definitely keep it on. I think PJP, while it's rare, has a really high mortality, and especially in these patients who have a lot of times lung and upper airway involvement, they're at higher risk anyway with those cavitary lung nodules and everything like that. So I still think it's very important. You still are slamming these patients with immunosuppression, even though we're trying to find ways to use less of it. So I would still use Bactrim or some sort of PJP prophylaxis if possible in these patients up front while you're doing the induction. And then about 6 months when you're using that maintenance dose, that's when I would consider pulling off.
Okay, got it. All right. Thank you. Some questions about IVIG, the role of IVIG in ANCA-associated vasculitis.
Yeah. So
is there any?
I think this is again comes to that whole throw the kitchen sink at them. I love IVIG. We have so little understanding of exactly how it's working, where it's working. I think that There aren't great trials looking at IVIG. I don't tend to use it much in this population. I do use it in those sick myositis patients or inclusion body myositis, you know, those types of things. I would consider it maybe as a holdover to try to buy some time in a very sick vasculitis patient who's actively infected. But that's really where I would use it, more as a stopgap to give me some time to treat an infection or treat possible sepsis while I'm waiting to sort of pull the trigger on my heavy duty immunosuppressive agents. I don't use it regularly outside of that.
Here's a question. How often do you see hypocomplementemia in ANCA-associated vasculitis? And with regard to avacopan, was there an outcome measure of hypocomplementemia and response to avacopan for induction therapy?
So in terms of the first question for how often I see hypocomplementemia, I don't see a lot. I mean, it's post-immune, in terms of deposits, but I don't see a ton of hypocomplementemia in my ANCA vasculitis patients. I feel like generally their complement levels serum-wise are normal. Once I'm hitting their immune system, I'll see, the low immunoglobulins. You worry about the neutrophil count. Sometimes their complements can go low, but I don't generally see a ton of hypocomplementemia personally. Again, there might be different experiences at different centers. In terms of the avacopan data, it's not available yet. So this is very early data. There's some information out there, but there will be a publication eventually, and I think hopefully it'll give us a lot more insight into the subgroups and what they measured pre and post treatment in each of those groups, but I don't have that information available yet.
Some people are asking the question of whether you use Bactrim for limited disease, not for PJP prophylaxis. Do you have any information on that?
If they've got a lot of sinus stuff, then I will put Bactrim on along with, I don't use it by itself for induction or maintenance at all. I mean, I definitely will use, if in those patients where I'm using methotrexate for induction and remission, where I feel like they have quite mild disease, I would also consider using Bactrim. Again, I think about the renal function, self-allergies, things like that. I mean, Bactrim is great for certain things, but there are issues with Bactrim as well. Also, you're telling these patients to be on a ton of medicines, and the vasculitis population, they're sick. They tend to be quite compliant, but I still think you want to limit how much you're throwing at somebody. And so, if I'm saying take prednisone, take methotrexate, take folic acid, take Bactrim, take some calcium and vitamin D, and maybe throw in a Fosamax here and there. It's a lot to ask someone to take. So I think, I start out with the drug that I need. So that's usually going to be the steroid and the immunosuppressive non-steroid agent. And then I think second line to that would be my calcium, vitamin D, and the Bactrim. So again, I don't jump to it as a treatment, but I'll use it occasionally to try to keep inflammation down.
Absolutely, thank you.
So Anisha, I think we have time for one more question, and you mentioned this at the end, and I know there's no answer to this question.
Great, love those ones.
But the question really is, we don't really know how long to maintain people on therapy, but we're all doing something in our practice. So the question is, how does Dr. Dua assess this in her patients, and how do you decide on continuing maintenance therapy?
Yeah, this is something, all patients and all of us really want to know the answer to. So what I do, again, take it or leave it. Everyone's got their own experiences, but I worry about relapses in these patients a lot. And each time you get a flare of this disease, you end up with some sort of damage. And so I want to do everything I can to minimize damage. I err on the side of control versus not control. So as much as I know these medicines are toxic, I tend to try to keep most of my patients on some sort of maintenance. I go for about 5 years. So at least 2, but I tend to use about 5. And at that point, if they've been stable and not flaring, then I don't stop cold turkey, I space out. So if I'm using rituximab every 6 months, that's when I start doing that weird thing where I'm checking the ANCAs and spacing and doing things like that, where I say, okay, you've been doing really well. Maybe I can try to do 8 months. Maybe I can try doing once a year. So I don't stop cold turkey, but I do sort of try to space after that amount of time of being under control. The patients where I might give a little leeway and start spacing earlier are those who never had any flares, you know, who once they got into remission, they haven't had any relapses, who are MPO positive, who are having intolerable, you know, issues with the immunosuppressive agent and are, you know, are getting repeated infections, things like that, where I really want to minimize, or I'm having some impetus to make me pull down that dosing. Those are things that might make me, after 2 years, start spacing or pulling down a little bit quicker. I definitely would treat everyone for 2 years, some way or the other. I don't know if that
Thanks,
answers.
Anisha. Yeah, it definitely answers the question. So we are at 1 hour, and I would like to thank my co-moderator, Dr. Gruzman from HSS, and really, from the bottom of my heart, really want to thank Anisha Dua for everything she's done to get this project up and running and giving our first lecture, and to the ACR. I hope everyone has enjoyed our first session. We look forward to seeing you all again, sort of, on Wednesday, and we hope everyone stays safe wherever they are. Have a great day.
Thank you.
Thank you very much. Thanks.